gives me great pleasure to introduce a colleague of mine, a friend and colleague, Dr. Michael Holland, who is a medical toxicologist who has additional board certification in emergency medicine, occupational and environmental medicine, addiction medicine as well, and hyperbarics. He serves on the faculty of the Medical Toxicology Fellowship Training Program and is a consulting medical toxicologist at the SUNY Upstate Medical Toxicology Fellowship and for the SUNY Upstate Poison Center in Syracuse, New York. He lectures extensively regionally at the statewide level, nationally and internationally. Topics including forensic toxicology, impairment, occupational and environmental medicine, and in drug testing. He serves on the International Scientific Committee on Health, Environmental, and Emerging Risks to provide ad hoc rapid risk assessment and chemical threats to public health, consumers, safety, and the environment. He's a medical director of occupational medicine and employee health at Saratoga Hospital and has been principal medical toxicologist for the Center of Toxicology and Environmental Health in Little Rock, Arkansas. And he serves on the American Industrial Hygiene Association Emergency Response Planning Committee. He's a fellow of numerous professional organizations, including the American College of Medical Toxicology and the American College of Occupational and Environmental Medicine, the American Academy of Clinical Toxicology, and very charismatic presenter and great friend of mine. I've been looking forward to this presentation. I hope you all enjoy it. Dr. Holland, thank you for giving us this second webinar, and it's all yours.
Great, thank you for the kind introduction, Tim, and thank you all for getting up so early and to listen to this talk. And so I'll just get right to it. So as far as disclosures, I have served as an expert witness in matters of impairment by drugs and alcohol, including the cannabis impairment, both for defense cases and plaintiff in civil cases and for the district attorney's office. How about marijuana and impairment, the facts that we know? So cannabis is obviously the most abused drug after alcohol worldwide, not just in the United States, but worldwide. And we know that it causes impairments of tasks that are necessary for safe driving. We know that. And more recently, the FARS data on fatally injured drivers shows that cannabinoid use in fatally injured drivers doubled between 2007 and 2016. And here's where you can see this. The fatally injured drivers tested positive for drugs, 25% in 2007, up to 42%, but the cannabinoid on the right-hand side, 8% in 2007 and more than doubled. It's 18% in 2016. Now, that doesn't mean that the cannabinoids cause their fatal accidents, but that's what you infer, or we fear that that's the case. And as far as confirmed toxicology results from drug recognition expert exams in 2017, you can see here that cannabis was 38%, and these are based on more than 33,000 evaluations. So it's obviously prevalent. So here's some old information that was quoted. It's often still quoted, et cetera, but it's from 2004, and this is from the National Highway Transportation Safety Administration. So we know marijuana impairs performance on driving simulators for about 3 hours after use. The main things that they see impairment is decreased car handling performance, reaction times are prolonged, they lose the ability to actually, or impaired ability to judge the time and distance estimations, maintaining lateral travel, so staying in the lane, subjectively sleepier, and some incoordination, and decreased vigilance, especially in long-term monotonous tasks. Many seasoned users perceive their impairment and can briefly improve their performance by driving slower or really concentrating, but they lose the ability to do that very quickly. And so again, it's more prevalent on monotonous, prolonged driving. And the greater the demands, the more critical the likely impairment will show up, obviously. It seems to be one of the overriding things in many of the studies on impairment in driving related skills, the decision time to evaluate a situation where something needs to take immediate evasive action is where the most impairment shows. In other words, something like a car stops in the road in front of the driver and they need to know, okay, they've stopped, I need to slam on the brakes or I'm going to hit them. And that's where the defect seems to be the most prominent, or being able to steer out of the way of a sudden change in the roadway in front of you. And of course, mixing alcohol and marijuana can dramatically produce effects, but more so than either drug on its own. So definitely additive effects. So jump forward to 2017. So 13 years later after that, fact sheet was published, and the NHTSA did a report to Congress. So this thing is, some 300 some pages, and it's got a lot of historical information and a nice summary of all of the science and the data that's out there. But what does it conclude? I think it's mainly a whole lot of nothing, because it doesn't conclude anything new, and it's just muddies the water more so because that's the way the literature is. So they note that one of the overriding conclusions on this report to Congress was that the poor correlation of THC concentrations in the blood, and I'll get to that, why that is discussed. And so they feel that setting per se levels is not meaningful. I disagree with that somewhat, but I'll find out later. And then what is known about the prevalence of marijuana impaired driving and the crash risk is reviewed. So they just review the literature, but they don't make any conclusions or say this is what the deal is, and this, so it's kind of a frustrating thing. So what do we know about marijuana and impairment? So there's psychomotor tests that we use on in controlled environments where people are given a fixed dose of marijuana, and we know that those things can measure attentiveness and vigilance, perception of time and speed, and acquired knowledge. So that's the cognitive and psychomotor tests. And the adverse effects you see is that complex tasks requiring divided attention, which is that's the decision of drive. The definition of driving is you got multiple things going on. You got to monitor your own speed, your place in the roadway, the cars around you, pedestrians to your left and right, distractions of the radio on or whatever, or other passengers in the car. So the complex tasks and divided attention is really what driving is all about. And then tracking, motor coordination, reaction time is critical, and visual functions. And numerous studies documented additive effects with marijuana, again, like we've talked about. Okay, so how do you detect this in somebody? How does a police officer do? So the DWI detection for this using a standardized field sobriety test are basically, that's been worked on for a long time. As you know, alcohol has been, problem in the highway and driving for a long time. So this has, had a long test of time. And so the three main tests that do is the horizontal gaze nystagmus, walk and turn, and one leg stand. And those have been validated as about 73 to 80% accurate for alcohol, if each one of those. And there's the whole stepwise things. If you look at how they do that, there's point scoring for each error that you make on these things. And so they combine that with the odor of alcohol and slurred speech, and the field sobriety officers are pretty good at detecting alcohol impairment on most people. But it's not really been validated for cannabis, and many of these things don't really get impaired so much that it would trigger a positive finding on the field sobriety test when they're impaired by cannabis. So the best test probably is the one leg stand. The horizontal gaze nystagmus is useless really, because it's not applicable to THC, because if you don't know what horizontal gaze nystagmus is, when the officer asks to hold the head still and then follow the finger or the pen light all the way to the extreme lateral gaze, and you'll start seeing nystagmus, which the eyes will beat this way and if you get horizontal gaze nystagmus by 45 degrees away at this angle from midline, that's really intoxicated. So it gets worse as you get more intoxicated, but marijuana doesn't cause that. Other sedatives, drugs can, and other drugs, but marijuana doesn't cause that. So it's kind of useless. The physiologic findings on marijuana intoxication would be conjunctival dilatation, so bloodshot eyes, and tachycardia are the two most common things. And they look for that, but I think anybody gets tachycardic when the cop pulls them over. So I'm not sure how useful that is as a discriminatory. Studies were difficult because there was, if you got federal funding, you couldn't use marijuana because it's Schedule I drug. So many studies use oral dronabinol because it's a legal drug. It's dronabinol is THC synthesized. So they give some tests use oral doses of that, and they found that these doses are about equivalent to 0.08 BAC on the road driving tests. But interestingly, there was undetectable, that impairment that they felt they found with that was really undetectable in standard field sobriety tests. So you can see how, there's a disconnect between, we know that we think we know, and a lot of studies have shown impairment, but to detect it as a field sobriety test is the studies aren't there, or the tests on the roadside are not there. You can get them in a driving simulator and show impairment, but that takes a long time, and that's not practical, obviously, on roadside. So they're obviously more accurate that way, but that's not a real life option. So on road tests, actually, some of the low levels of THC, the test subjects feel impaired. They tell them they feel impaired, and they actually drive slower and more carefully. So it's a difficult problem, and we don't have a great solution to it yet about proving impairment at the roadside. But again, the single overriding most common deficit is deviation of the lateral position in the lane. So weaving back and forth in the lane, and then recognizing dangerous situations which would require immediate, urgent, or emergent action, such as slamming on the brakes or steering out of the way of a dangerous situation. And those are the ones I've seen the most in my career of people evaluating people for impairment with driving. Okay, so this is the drug we're talking about. So THC is the active tetrahydrocannabinol, and it's rapidly metabolized to 11-hydroxy-THC. And these two are both equipotent in their psychoactive ability. And then it's further oxidized at this carbon, at the 11 carbon, to carboxylic metabolite. And this is much more water soluble. It also gets glucuronidated and excreted in the urine. But all of these are stored in fatty tissues and in the body. And the THC, carboxy-THC, this non-psychoactive metabolite is very high tissue stores in chronic users. And they can excrete it in urine tests for weeks after their last use, even if they go completely in a cold turkey and stop. So it's the subject of, that's the metabolite that's tested for in urine drug testing in the workplace, et cetera, and for drug test monitoring. But it also has some implications in blood testing. But so that metabolite is what we're looking for in the urine. Like I just said, that there's the active metabolite and then the inactive metabolite. The levels of carboxy-THC do not cause impairment, but they can discriminate the occasional user from the chronic user. And this study that it referenced there, I think it's Fabricius, that anybody that was greater than 40 nanograms per ml in the blood, in the serum, regardless of what their THC or hydroxy-THC was, if their carboxy is greater than 40, they are not an occasional user, and that's a chronic user. The problem with carboxy-THC, though, is that many old studies looked at total cannabinoids, and they just lumped everything in it. And whether it was present in blood or urine, they said, okay, this person has cannabinoids in the body. And that's part of the problem why some of the older studies couldn't, or many of the studies couldn't show impairment, because someone does not look impaired and they have carboxy-THC in their urine. Well, they're not impaired. That just means they may have used marijuana in the last week or more. So because it has such a very long effective half-life because of all the tissue stores. And when you're measuring for THC, it must be done very carefully. Because in blood storage issues, there's loss of 50% at 8 weeks if it's not kept at the really deep freeze. And if it's put in plastic vials, the lipophilicity tends to make it bind to the walls of the plastic vials. So it's got to be stored in glass tubes. Generally from the literature, we know that after smoking a standard dose in volunteers, the THC blood levels peak at about 5 to 8 minutes after smoking. And, depending on the dose, can be very high, over 100 nanograms per ml. But right at that early time, those people aren't really even high yet or impaired. They fall to less than 20 at about an hour, and then less than 10 at about 4 hours. This is in the non-chronic user. So that the blood levels you can see, and it's but not correlated with impairment because it's actually the brain level. So it's after distribution from the, you have absorption and then distribution. So the distribution to the brain is when the impairment starts. So this is just an example of the difference in metabolism. So this is alcohol. So we see alcohol was when you first drink, it peaks up here, and then diffusion and distribution. And then in the relevant physiologic range for alcohol, it's a zero order kinetics. So in our standard graph, you can see a straight line, down. And that's how, that's why we can back extrapolate for alcohol. And then it doesn't get to first order kinetics where you have a fixed percentage goes down each per time. That's not till very low range. So the average metabolic rate is about 0.015 grams per hour for alcohol. And so that allows the back extrapolation, because you can see how on this graph, this is the minutes after an infusion. You can, you could take a line here and then pick a line there, and it's a straight line, and you can find out what that person's blood alcohol level was, an hour or two beforehand, providing that absorption and distribution has all been completed. And frequently that's used in DWIs because obviously you get the blood alcohol an hour or two after the arrest is made or after the accident. And so that's when you use the back extrapolation. But for marijuana, as you can see, this is the example on the upper right this is first order kinetics. So it falls 50% in a half-life. So these were your half-lives, but you don't know where you are as far as when the peak was when you have a curve like this, so you can't back extrapolate. And the curve on the left, this is actually from studies of, you get a feeling, you can get a feeling for how this is first order kinetics here, because this is the actual curve for marijuana. So you can't back extrapolate. So it's not as easy. So using a blood value that you get after a rec is not very useful, because you don't know where they are. So it makes decisions about impairment based solely on a blood level as difficult. And this is from the PAPAFITU from 2005, showing they did some standard field sobriety tests and found these people were still somewhat impaired at 75 minutes and 100 minutes. But by the time they got to 125 minutes, they didn't feel that there was much impairment detectable on the field sobriety tests. And there's the problem with the field sobriety tests. So if you look at all the studies, we know that the impairment doesn't really start until 20 minutes after the peak, and that's because it really starts to get into the brain by then. But what do the blood levels mean? Impairment lasts about 3 to 5 hours from the older studies of the smaller doses, the less potent marijuana. And some of the newer studies shows it lasts longer, and that makes sense because the marijuana is more potent now. But the perceived high by users is substantially shorter than what the impairment that's been shown in studies. So if somebody gets high and an hour or two afterwards feels that they're back to normal, they may still be impaired for 5 to 7 hours, but they make the decision to go drive, and there's where the problem is. There is some evidence of the hangover effect in a number of studies for about 24 hours after impairment of skills that are necessary for safe driving, and residual neuropsych effects seen for 12 to 24 hours. So there's a whole lot of stuff out there, and how much that means to acute driving impairment is subject to debate, especially when you're trying to say, oh, well, the person's a chronic user, and so they're tolerant to some of these effects. Some of the stuff that was used in the past, and I don't think it has much application now, is Eustace equations for estimating time since last cannabis use. You can see this was developed in 1992, but I'll get to in a minute why I don't think this is really very applicable. But if you used the concentration of THC and carboxy THC from the blood test on a driver, you could plug it into this formula and it would give you a range of how long ago it was since they last smoked. And if you got like, okay, it was an hour ago, then you would say, okay, this person is probably impaired because impairment lasts 3 to 5 hours after you last smoked. But unfortunately, it was based on science that's almost 30 years old now. And time since last smoke made sense when you had those kind of values. Street cannabis at that time was about 3% THC. By 2012, it was 4 times higher at 12%. It's now even higher with marijuana legalization and hybridization of plants and the technology involved in making more potent marijuana. And so the psychomotor effects after edibles especially lasts a lot longer. So I think it's reasonable to assume that the higher dose ones that marijuana that's out now will last longer and effects are going to be more impairing due to potency and dose. This graph is from a recent article showing the average percent THC in medical versus recreational marijuana. You can see the average, the mean is at 20%. And those studies were using 3% THC. And you can see some of these are really high. And then CBD is over here on the other side that's more all over the place. But the impairing THC is quite high now compared to previously available. And from this same article, this is just a compilation of what's available both recreationally and medicinally in different states. And you can see the different states here. And the green means the THC there was more than 15%. The marijuana available was more than 15% greater than. So you can see most of the states there, far and away, the majority of the graph is green. So that means most of the marijuana that's available there is more than 15% THC. So it's quite a bit more potent than it used to be from a lot of the older studies that were done on in the 90s and 80s, et cetera. So what do the plasma levels mean? How are we doing for time? Okay. Visual tracking is impaired with THC is greater than 6 in the serum. Attention is impaired at greater than 9. Visual functions impaired greater than 12. And so this is the relationship between the field sobriety tests and the performance on that and the delta THC in the blood. And so impaired critical tracking greater than 2. Stop signal test is greater than 5. And Tower 11 and greater than 5. And you can see why many countries and states kind of look at 5 nanograms per ml as the cutoff. That's generally what's sort of settled on in a lot of places. Some are lower. And this is a graph I put together of studies that I actually reviewed. And it just shows you that, some of them are driving while under the influence of drugs. And it just shows that the levels are, kind of all over the place, but very low levels are shown to have an increased risk ratio or an increased odds ratio greater than 2. So it seems like 5 nanograms per ml is the sort of a reasonable cutoff, but only very few states have done that. So what else can you do? You can also use cannabis and influence factor. It's also known as the molar metabolite ratio. So what you do is you take the actual THC concentration, you're dividing it by its molecular weight. Same thing with hydroxy THC, because these two are on the top because they're in the numerator because they're the psychoactive ones. And then you're dividing it by the molar ratio of the serum level of the carboxy divided by its molecular weight. So then you get the molar metabolite ratio, and you multiply that by 10. And so if it's greater than 10, it predicts an impairment analogous to a BAC of about 0.11. So you can see that would be quite impaired if your 0.08 is your standard for BAC. It declines rapidly, but it also can be useful as a biomarker of recent use. A recent study, well, not all that recent now, 9 years ago, 10 chronic users, so a small study, there's only 10 people, found that the CIF or the MMR was not really predictable in all regular users. And part of that, I think, is because the denominator is so large in regular users. They're all quite a bit greater than 40 nanograms per ml because of the tissue stores and the buildup and the constant excretion into the blood of the carboxy THC. So your MMR is going to be low only because your denominator is so high. I think that's my feeling why that's not useful. So why is all this important? That is because recreational marijuana now is available in 18 states. You know, this keeps climbing every time I do this lecture. And as you can see, we're surrounded by it: Maine, Massachusetts, New Jersey, Vermont, and now New York. So it's only the border states in New York. The only ones that aren't are Pennsylvania and the little bit of Ohio that we sort of touched way western end. But it's also legal in Washington, D.C. and some of the territories, and as well as our neighbors to the frozen north. So, you know, we're all around legal marijuana. So medical marijuana is present in legal in 36 states. And you want to know, okay, with all this legal marijuana now, is driving under influence of drugs or driving, driving under the influence of drugs is what DUID means. So the NHTSA roadside survey revealed a decreasing trend of alcohol use by drivers between 73 and 2013. The percentage of weekend nighttime drivers testing positive for cannabis nearly doubled from 2007 to 2014. But just remember, the presence of the substance does not necessarily prove impairment. And the drug use around fatally injured drivers who tested for drugs went up from 25 to 42%. So, and that was the thing I showed you earlier, that they doubled in the detection of THC doubled in that time period, more than doubled. So recreational marijuana was introduced in Colorado in 2012. So the number of fatalities and crashes in which drivers tested positive for THC rose from 18 that was in the year immediately after it went to 2016. 3 years later, it was like 4 times higher. So that's just a raw number of those. That's not a percentage or implying impairment but not proving impairment. Okay, and since in Washington State was this next state to go positive, recreational in 2012 as well. So the number of drivers, I told you this earlier, went from 9% to about 18%. But only the drivers involved in fatal crashes who tested positive. They didn't really assess whether that was actually impairment. So what do you do? So you got to get, well, all these things are circumstantial and there's not really any control. So what's the best thing as medically as we look for is a case control study. So that's the holy grail, right? So what do you get? So the drug and alcohol crash risk, a case control study was done by the NHTSA, and it was in Virginia Beach, Virginia in 2016. It was pretty elegantly studied. They tried to do as well as they could. They sampled more than 3,000 crash drivers at the scenes of crashes and 6,000 control comparison drivers. And what they did for the controls, so they did double the amount. They went to the same roadside at the same time, 1 week exactly after these crashes, so that you got this, like if it was a Saturday night, you got another Saturday night, that kind of thing. And they did comparison drivers that weren't involved in crashes. They collected more than 10,000 breath and 9,000 oral fluids and 1,700 blood samples for alcohol and drugs. So the results were that alcohol is the largest contributor to risk. No surprise there. And for THC, the odds ratio was only 1.25. So that means like there's a 25% increased risk of crash if you have THC on board. But then once they corrected it for gender, age, race, and presence of alcohol, the risk for THC went away completely. So the risk was 1.0, no higher than the control. And they've also found that there was no increased risk for alcohol plus drugs when they corrected for just for alcohol. So, if anybody that knows about drug and impairment and additive effects, none of that makes any sense. And so I think identified problems are this. The study examined the presence of a drug, but because of the small numbers, most of them were not able to separate the analyses by the concentration levels. And whenever you're collecting for drugs, the oral fluid can be done right at the scene, but for checking blood, it takes some time to get to the person to get someplace to get blood drawn. So then you can see the half-lives maybe gone, and the marijuana is not detectable. It also disagrees with years of research on that THC is impairment for the skills necessary for safe driving. It didn't evaluate the dose response effect that we know it has in all the previous studies. And it really contradicts the overwhelming evidence of additive effects of drugs and alcohol. We know that for benzos plus alcohol, marijuana plus alcohol, opioids plus alcohol. So and also it didn't differentiate by type of crash. And I think this may be the underlying problem with it. As we mentioned before, THC has a larger impact on that attention-related skills, that necessary vigilance, on long monotonous driving, and then all of a sudden have something stop in front of you, and you need to take sudden evasive action, slam on the brakes, etc. And that's where THC has the most impact. But it has less on behaviors that influence speed or aggressive driving, like alcohol does. Alcohol almost. Many times the alcohol impaired drivers has driven too fast for the conditions, and that's how they get in trouble. Whereas THC drivers tend to drive slower and take less risks because of their perceived impairment. The problem drinkers don't get the sedating effect from alcohol. They get a stimulatory effect, and sort of like Superman, bulletproof and invisible kind of thing. And whereas the THC impaired drivers tend to feel impairment, and they try to stay safer in driver's seat. So the per se laws, what do we do? It's per se laws, like for the alcohol, it's 0.08. That means if it doesn't matter, you don't have to prove impairment. It's just if your blood alcohol is greater than 0.08, you are per se impaired. So there's no proof needed of impairment. Many states have that. Only 6 have that for marijuana, and it's a certain level. And there's the states listed here. And there's, interestingly, as if you know anything about in Europe, the blood alcohol concentration tolerance is very low in Europe. It's like 0.02 or 0.04. So it's like if you drive with 1 or 2 drinks under your belt, you could be DWI in many European countries. Now they have the ability to have, easily affordable mass transportation, so people don't have to drive, but they're very low tolerance. The same thing in many European countries for marijuana. And the reason being is that, which makes sense, their reasoning is that by the time you get the person to someplace that can draw their blood, you've gone through a couple of half-lives maybe. And so they use mainly the limit of quantitation of the lab for testing for serum. If you detect it and you can quantitate it at the limits of quantitation of that actual lab, you're per se impaired in these countries. So it's pretty interesting what the different municipalities, states, countries use for this. So this is a map of the United States, as you can see, and so only one has the permissible inference law. That's Colorado, as you can see, is the green. So the 6 states with the per se are the yellow, sort of the orangish ones. And then under the influence, the gray ones, most of the bulk of the states require that you have to prove by some sort of objective test, roadside or otherwise, that the person's impaired. And then the blue is zero tolerance law. So this is ones that, some of these states that the law says any amount of cannabinoids found in the body. So you could get carboxy THC in the urine and be charged with impairment in some of those states, which really doesn't make sense, but that's the reality. So finally, I wanted to talk about, this is the big controversy, is do chronic cannabis users exhibit impaired driving in the absence of acute intoxication? So the epidemiologic studies have not been able to show definitively that chronic users are impaired. This study by Dahlgren in 2020 uses a desktop driving simulator, and it showed abstinent chronic users perform worse than controls on multiple measures. But the users were abstinent by self-report only, and for 12 hours is what their requirement. But they didn't do a blood test to prove that they were abstinent. So that's, I think, some of the problem. But by the sub-analysis, when they adjusted for the age of first cannabis use, those users who used cannabis first time before age 16 years of age, it showed that that's where the chronic users impairment was. And the people that started after that did not show the impairment. And it was really linked to the impulsivity problems on the people in that group. Here's another study from Kroon. This is in the references in the back of using, these are looking at for cognitive. And if you look at it, there's sufficient evidence. This is a meta-analysis of all the studies showing short-term and long-term effects in chronic users. And so there's some sufficient evidence for attention control is impaired, but there's insufficient evidence for most of the other things that you would like to see, but this is cognitive and really not looking at a lot of psychomotor skills for driving. Then in this, most recently, there's a meta-analysis by McCartney, and that was just published this year. And they looked at 80 publications looking at more than 1,500 outcomes to see if THC and driving impairment and what were their conclusions. So the several measures that we talked about, lateral control, tracking, and divided attention were necessary skills. And they found a dose-dependent effect for the peak THC concentration, either if it was inhaled or edible. And they felt that the inhaled THC effects subsided at about 5 to 7 hours. Again, not like the 3 or so hours, 2 to 3 hours that the earlier studies saying. And I think that has a lot to do with the dose. Edibles actually lasted longer, and you can think about that. You don't get as high a peak with edibles. It's a slower time to peak, but a more prolonged effect because of the oral intake. And it appears that regular cannabis users, so the chronic users, like smoking every day, they experience less effects than occasional users, but it's not zero effects. And that's, I think, one of the take homes. But there is quite a bit of difference between the acute effects of a non-seasoned user and then the chronic effects and the acute effects on chronic users. They identified a lot of problems, the small number of studies involving regular cannabis users, and the regular cannabis users are really a heterogeneous group. There's some that smoke, 2 times a week, and there's some that are smoking all day long. There was variable abstinence periods prior to smoking in most of these studies because it's a meta-analysis of 80 studies. None of them used blood tests to verify acute abstinence. So we really don't know if they were abstinent or not. So if they're already high in their baseline and then you test them again and they smoke, you're not going to have a difference, but there may be a difference if you had proved that they were actually abstinent. The THC doses in these studies are all fixed because that's how you have to do it in the study. But in real life, people smoke or use edibles or whatever. Chronic users, they use it to effect. They smoke enough to get the effect that they're achieving, the buzz that they want. And then very few looked at any longer post-treatment intervals. 4 to 6 hours was about the average. So that concludes the lecture, and I'll open it up for questions if anybody has any. And thank you again for coming up, attending so early in the morning and listening to me.
Mike, that was great. And for everyone, this is recorded and the slides will be available on the NYSAM website as well as through MISNY. There have been a couple questions in the chat, and you answered one regarding the per se. I think Dr. Fox had asked, why does the THC concentration matter? If people smoke less of more potent cannabis, then total dose may not be different. You can see.
Yeah, that's a good point. So people generally titrate to the effect. So if they're they look for the buzz that they're looking for, and if they're used to the concentration, it's a more concentrated marijuana and they know it, they may only take 2 or 3 hits to get to the effect. Whereas the older weed that was not as potent, it might take a whole joint to get to that effect. You're right. Most people titrate to the effect they want. And that's why smoking is much easier because you get the blood levels rising so quickly. Edibles, it's very difficult to, for people that are first starting edibles to titrate it to the effect they want. And that's where people get in trouble, so with the first doses, they take a bite and a half hour later, they still don't feel anything. And then they eat the rest of the cookie and then it slams them. But they generally learn either not to use edibles again or to titrate the dose a little better and be more patient.
Dr. Naka has a question. And can I ask you to look into the future and predict where we are going as a society? Will there be breathalyzers capable of detecting THC and metabolite? I also didn't hear you talk a lot about the utility of the THC to the carboxy THC ratio.
Yes, so that's very interesting. I think what's going to come is going to be the roadside. This is just my guess, but the technology's there. The oral fluid instant tests are going to be the roadside tests. There's a little bit of trouble with that because, as we know, when you're looking for a THC in a blood test, you're looking for hydroxy THC and parent drug THC and not carboxy. But when you do oral fluid and you're smoking, you have active THC, the parent drug, in your oral fluid just from it passing through your mouth. So actually, oral fluid uses THC and carboxy THC. So if you were completely naive and don't smoke at all, and then you smoked weed, and then I did a oral fluid on you, you would have no carboxy THC right after you smoke, but you'd have all THC, but you wouldn't be impaired at all yet because you don't have that. All that THC that you got in the oral fluid was from, from the saliva from when you just smoked it. So it has to have carboxy THC in it as well because it has to have a metabolite, knowing that you're getting actual serum THC because of from the oral fluid. So there's little idiosyncrasies about it, but I think that's what's going to be the roadside thing. That's the sort of the equivalent of the breathalyzer, and then the blood test. When you flunk the oral fluid thing. But the problem with that is just like the breathalyzer, that's going to be the the signal to say, okay, they need to go for a blood test, but you can back extrapolate from a blood test 2 hours later on an alcohol test, but you can't with marijuana. So that's going to be a problem. Marijuana is not volatile out of serum, so a breathalyzer I don't think is going to ever be useful, but it may. I'm not sure. I don't think so.
Dr. Seltzer had his hand up. Michael Reyes, can you unmute Dr. Seltzer? Or Jeff, you may be able to unmute yourself.
Did I?
He can unmute himself.
Yep.
Okay, great. So I'm sorry, I was just in the middle of trying to put it in chat. So I wanted to draw on you. First of all, thanks for a great talk. That was wonderful. And I just wanted to draw on your experience. I think it's pertinent as an employee health service medical director. I've seen communications from the Department of Labor in New York State to employers talking about changes in drug testing laws, given the legality. And I wondered, as someone who works in an employee health service where you've got safety sensitive employees, how that changes what might be your practices. And, having asked that, I don't even know what your current practices are. But, just broadly, pre-employment testing, for cause testing, those sorts of things.
That's a great question, and thanks for bringing that up. So as soon as the law passed in April, we took marijuana off our pre-placement urine drug tests, and we essentially took it off our for cause too, because detecting carboxy THC in urine is useless for detecting impairment. It just shows use. And so now that it's a legal drug, the employment lawyer says, you can't make any employment decisions based on legal use of a legal substance. It would be like, not hiring somebody on a Monday morning because you saw him drinking at a bar on Saturday night. It's allowed to. He's over 21. So, it's legal to have marijuana in your system. In your urine on Monday when you come for a pre-employment drug test. So we've taken it out of all pre-employment drug testing for our hospitals. And we advise in our occupational medicine practice, we advise all our other employers in New York State to do the same on pre-employment, because you can't make employment decisions based on prior use of a legal substance. Now for cause, it gets a little dicier because, even if you do a urine drug test and it shows marijuana, means you used it in the last week or 2 or 3 or whatever, and it has nothing to do with acute impairment. It never has and never will. So what some employers are doing is they're making the person subjected to a blood test and looking for serum level of THC. So.
That's really interesting. Thanks, Mike.
Sure.
If there's other questions, please chat or could also unmute and talk. I had a couple of questions. There's an emerging literature on concussion and evaluating whether or not someone has deficits related to concussion using, iPad and a series of tests and other things. Do you think that that has any application to impairment related to cannabis or other drugs?
Yeah, I think, Tim, that's a great point. You can, the driving simulators, obviously you can't bring to the roadside, but the iPads with following with the pen and following, you can do similar things like lane deviation and tracking skills, et cetera. And so I think those are in development, and some people are using those in studies. And I think that may end up being the roadside, part of the roadside field sobriety test armamentarium. And that would make a lot more sense than, looking for horizontal gaze nystagmus and, the walk and turn, because it doesn't help. That's not helpful. But that's a really good point. And I think that's where research ought to be concentrating on, because, eventually, it's going to be legal nationwide. And so then we're going to have to address it, and then the feds are going to have to address it, on the highways.
That brings it question Dr. Naka brought up, but again, exceptions, as I understand, are with DOT and DOD. So, that was Jennifer Farragher. And Dr. Naka also mentioned, is it different for some employers based on federal law?
Yes, good point. Very good point. So we did that for state, but the feds still consider marijuana a Schedule I substance. And so it's still illegal under all federal agencies. So when we do truck driver, the NHTSA, the Federal Motor Carrier Safety Administration, FMCSA, they're all part of the DOT's, the Department of Transportation agencies. So that's the highway, so truck drivers, the FAA, the FTA, the Transport Authority, the FAA, the FRA, the railroad, and, pilots, FAA. So all those, and the Pipeline Administration and the Coast Guard. So all those people are federal agencies, and they're subject to federal drug testing, and it's still illegal under the feds. So even if it's legal in your state, if you use marijuana and you're not subject to the drug testing of those federal agencies and you test positive, you get dinged. That's it. You used an illegal substance under the federal guidelines. And so it is really problematic for employers that have both federally regulated drug testing for their drivers, and then for their warehouse people are not federally regulated. So it puts them in a quandary, but that's a really good point. It's still illegal under the feds. And so you can't use it. And interestingly, CBD is now, quote, legal everywhere because it's no longer illegal, but it's that kind of quasi, but CBD is still not, approved for DOT truck drivers or anything like that. So, it's not detected on a drug screen, but you're actually not allowed to be using it under the federal agency's rules.
From what I understand from our prior webinar, New York State has formed a board or plans to research this in terms of studying ways to determine impairment. Do you have any insights into what direction they're headed, or is it too preliminary?
Yeah, I heard that, but I don't know anything about it, and they didn't ask me.
We've got time for other questions. I have a couple of others. Again, great lecture. Is the hangover effect different for chronic users versus infrequent users? And then I've seen some literature, and as well as we were talking about a case the other day in Colorado where someone claimed that they had withdrawal, and that was used as a defense in explaining high levels and that the high levels were actually protective rather than impairing. Can you comment a little bit on the difference in hangover effect from acute and chronic use and then cannabis withdrawal?
So leave it to Tim to ask the tough questions that we don't have the answers to, but yeah, that's a really good question. So this is the way I feel about it. The acute use in the non-season tolerant person, there's been some studies, there's 3 or 4 of them that showed some hangover effect in some of the skills for about 24 hours. And the most quoted one was the ones they used airline pilots who, were not marijuana users at all. And they had them using a flight simulator and they smoked and they got impaired and it was definite. And then they retested them 24 hours later and they were still somewhat impaired for a little bit of this stuff. And then after 24 hours, it was gone away. And so that was quoted a lot. And then there's some other ones, neurocognitive impairment on, people afterwards. And so then, but when you look at the studies of the chronic users, when they admit them to a locked ward where they have no ability to get any marijuana and they just test their blood every day, they have THC and many of them have hydroxy THC excreted still in their serum, days later, 7 days later. So I think that those studies that I quoted about the neurocognitive impairment in chronic users, I think they're neurocognitively impaired chronically because they always have a blood level of THC and hydroxy THC, and they always have a brain level of it too. And you won't know what impairment goes away until they completely excrete, and it may take weeks for them to get rid of it completely. So I think that's the problem. But I think the chronic impairment that's shown in neurocognitive studies of chronic users is because they have chronic levels of the impairing drug in their brain and it's detectable in their serum. So that's what I feel. But the difference between, when you test them baseline, these studies showing the person's baseline, they said they was abstinent for 12 hours and they acutely smoke and they don't see a whole lot of impairment in the chronic users. Well, because their baseline is already impaired. So when they get back to their somewhat impaired baseline, it doesn't look like they have had a lot of changes. But in reality, that would be a lot of change if you, got them completely abstinent and it went away from them completely. But, that would be very difficult to do and prove experimentally. But I think, logistically that makes sense. And your thing about withdrawal, Tim, we know that somebody who gets wasted on alcohol, gets up to 0.25 and, shouldn't be driving, but they do and they get into trouble. Well, if you take that same person, they got 0.25 and they waited till they were completely sober, but they're such hangover, they're hungover and their alcohol level may be 0, but they're, sleep deprived and it was a terrible sleep and it wasn't good REM sleep and all that stuff. So they're impaired even when they're sober immediately the next day, because you're not functioning well at work, you're not functioning well behind the wheel anyway. So I think there's that acute withdrawal kind of thing, acute hangover type effect from just not having the drug and just disrupting your sleep patterns, et cetera.
Yeah, no, that's a great comment regarding alcohol in particular. We've reached the time at 8. You've been recommended for the regulatory group to participate in New York State cannabis regulatory process, at least by some of the audience. Excellent presentation. Thank you so much for doing this for the New York Society of Addiction Medicine and Medical Society of State of New York. Mike, has been recorded and the slides will be available as well as the discussion afterwards. So I want to thank everyone for attending early and let others know. It should be up on the websites within a week, I believe. So again, thank you and everyone have a great rest of the day. The next webinar will be announced shortly.
Thanks, Tim. Thank you, everyone.